This is the lecture on addressing psychological disorders. In other words, how we treat psychological disorders. If you haven't already done so, go ahead and open up the PowerPoint on addressing disorders, treatment approaches for psychological disorders. When you first open up the PowerPoint presentation, you're going to see an unusual slide that has fairly unusual images. What I want to first talk about, just to give you a framework for the treatment of psychological disorders, is a little bit of history in the treatment of psychological disorders. It is clear that way back in ancient times, psychological disorders or mental illness was not very well understood. Most of the time, people who experience psychological disorders were feared and misunderstood by those around them simply because there wasn't a clear understanding as to what was happening with this person. So in ancient times, some of the causes that were attributed for psychological disorders included things like possession, witchcraft, or the influence of the moon. So in possession, we can talk about possession from demons or otherworldly spirits that were causing people to behave in a bizarre or unexplainable manner. We can say that people had spells cast on them by witches that also caused them to behave in bizarre and unpredictable manners. And then interestingly, it was also believed by some that mental illness was really the cause of different phases of the moon. In other words, the different phases of the moon could influence our behavior and cause some people to behave in decidedly bizarre ways. So typical treatments were not very nice. Let's just keep it that way. They were certainly harsh and barbaric. If you take a look at the images on the PowerPoint slide, you're going to see two common, quote, treatments for people with psychological disorders. The first one is called trephining or trepanning, and that is spelled Trephin, trephining, or trepanning, Trepanning. In either of these procedures, well, they're the same procedure, a hole is drilled into the skull because it was believed that if someone was possessed by a demon or some kind of spirit, that maybe if we could let out the spirit, then the person would be cured. As you can see, the holes that were made in the skull were quite large, although people lived a normal life even with this hole in their skull, as long as infection was prevented. In most cases, the bone from the area that was drilled out did not grow back. So even hundreds of years later, when we uncover some of these skulls, you'll see that the holes are still there. It appears as though the person at the top had repeated procedures because it looks like there are actually 3 holes in that person's skull. So either several holes were made at one time or this person received repeated trephining or trepanning. Another procedure that was very common as our surgical knowledge improved was the use of a lobotomy. And that's the last image that you see on the slide. Lobotomy is spelled Lobotomy. And in this procedure, some sort of instrument is inserted into the brain to either sever connections between 2 of the cortical lobes, usually it was between the frontal and the parietal lobe, or simply to incur damage within the frontal lobe, such that a very small scalpel was inserted into the brain tissue and then just a slight movement back and forth was made to do damage within the frontal lobe. The results of this procedure yielded a person who was very emotionally sedated, a very flat or blunt affect, not a lot of mood. But then again, people who were subject to lobotomies were often people who were very aggressive or who had other behavioral problems that made them very difficult to control. Unfortunately, lobotomies were very much overused, and not clinically recommended for most of the patients who actually received them. Patients who were institutionalized did not fare much better. People who had severe psychological disorders who ended up in some sort of long-term institutional care were also treated very poorly. They were taken to institutions known as lunatic asylums. Notice the word lunatic. The word lunatic has the root word luna, which means moon. So again, this idea that people's bizarre behavior was influenced by the moon is even recognized in the name of the facility and the name given to people with psychological disorders, lunatics, affected by the moon. The other word in that phrase is asylum, and the word asylum means refuge or protection. So people with psychological disorders were taken to a facility called an asylum, seeking refuge or protection from the outside world, when in fact the conditions within these institutions were often terrible in their own right, and patients often fared no better when institutionalized than they would have outside with their families. Another common name for institutions for which people with psychological disorders were treated is called a fool's home. People with psychological disorders were often labeled fools or morons or imbeciles, and they went to, quote, homes designated for them. But again, the conditions there were not very good, and people did not necessarily live a happy, long life while in these institutions. If you take a look at the next slide, I want to show you a little bit of information about the types of treatment approaches that I would like to discuss today. Fast forwarding from historical and ancient treatment approaches to modern treatment approaches. What I have on this slide are two movies that characterize people with psychological illness and their, quote, treatment. Of course, Hollywood likes to tell their own story about people who are mentally ill and how they are treated, which doesn't necessarily represent the reality of the situation. Unfortunately, unless you or someone close to you has actually been through some kind of psychological treatment, all we have are the images that Hollywood gives to us, which are often very distorted simply for the sake of shock value or entertainment. So please keep that in mind. Treatment for psychological disorders is often nothing like how it is portrayed in the movies and on TV. If you take a look on the list of treatment approaches, I want you to know three general categories: behavior therapy, insight therapy, and biomedical therapy. Behavior therapy is something that is covered in the learning lecture, so I'm not going to go into that in much detail. But in behavior therapy, the goal is to change a person's behavior, not necessarily the cognitions that accompany the behavior or the underlying biological causes of that abnormal behavior. The goal is simply to change behavior. So behavior therapy is appropriate for people who have phobias, because we can use behavior therapy to treat phobias using flooding or systematic desensitization without ever having to get to the root cause of the phobia. That is a separate issue that may or may not reveal itself in therapy, but we can change the behavior toward the phobia target even without getting to the root cause of the phobia. Behavioral therapy is also appropriate for bad habits, things that people would like to break, such as overeating, smoking, substance use. These are all disorders that can be treated using behavior therapy. What we're going to focus on this time is insight therapy and biomedical therapy. Insight therapy is probably what you commonly think of when you think of what happens when you go to a therapist's office to discuss a problem that you're having. Insight therapy is generally known as talking therapy. This is where a client goes in to a therapist's office and sits and talks with the therapist. Now, the therapist is trained in different techniques and different ways of managing the conversation, but in general, problems that the person is having are revealed through talking. So talking therapy or talk therapy really encompasses what is meant by insight therapy. But I want you to know that there are several different types or approaches in insight therapy. The other approach I want you to know is biomedical therapy, and this is where we actually try to change the brain chemistry that might underlie a psychological disorder. So the two most common ways to treat a disorder biomedically is to use medication, usually in the form of pills, or electroconvulsive therapy. So I'll be talking about both of those in just a little bit. The reality is, successful therapy usually requires a combination of both insight therapy and medication when appropriate. Too often, people will simply have medication prescribed to them, so they take the medication and they do feel better emotionally, but the issues that underlie the disorder are never addressed. So it is not recommended that people simply take medication alone and don't do any kind of therapy, because in the end, you're not really addressing the heart or the source of the problem causing the disorder. If you take a look at the next slide, I want to show you an example of what I mean. These are some statistics that reveal the effectiveness of both therapy and medication, medication alone, therapy and a placebo, and then only a placebo. If you look on the y-axis, on the left side, you will see the relapse rate. This is people who lapse back into their psychological disorder once the treatment ends. So as you can see from this graph, the worst possible type of treatment condition is simply a placebo medication. Placebos are essentially sugar pills, and sometimes we see an initial improvement in symptoms, such as those related to depression or anxiety, when people are given a sugar pill and they are told that it is actually medication. The placebo effect is real. It can be an effective way to help people. However, it usually does not last very long. Giving someone a placebo and telling them it is medication is not going to lead to a long-term reduction in their symptoms. So as you can see, the relapse rate is about 90%. If we do therapy with the placebo, the relapse rate is a little bit above 60%. When we do medication alone, notice the relapse rate is still above 40%. So that is a person who is experiencing a problem for which medication is prescribed, let's say again, a depression or anxiety related disorder. They may feel better, but they may not end up getting better. 40% of people will relapse on their disorder. That's almost half, which indicates that medication alone is not going to help people overcome or deal with their psychological disorder. The best course of treatment, and the one that is recommended over and over again by psychologists, is a combination of therapy and medication. Notice the relapse rate is about 20%. What that means is that there are still about 20% of people for which therapy and medication don't necessarily work, but it also means that for 80% of people seeking treatment, it will, and those are the best odds that we have currently. If you take a look at the next slide, here is another statistic for you, because sometimes people assume that they will improve significantly with just one or a few sessions in therapy, when in fact that's not necessarily the case. If you look across the bottom, you will see the number of therapy sessions, whether these are weekly, bi-weekly, or monthly. And then on the y-axis, you will see the percentage of patients recovered. So notice we have a pretty clear trend on this graph. Patients usually need a significant number of sessions in order to recover from their disorder. So to get upwards of 70%, which is a pretty good effectiveness rate, you're looking at about 45 sessions. So if you think about that, if someone is going to a therapist once a week, that is almost a year of therapy. Almost a year. So this is something that people really have to commit to if they want to get better. Figure on about once a week for a year in order for most people to improve significantly in their psychological disorder. If you take a look at the next slide, I just want to give you a few more statistics because this one is actually particularly shocking. What you see here are two circles. The red circle indicates the percentage of the population that has a psychological disorder within a year, about 28%, somewhere in the ballpark of 1 in 4. The blue circle represents the percentage of the population receiving mental health services. In other words, people who actually receive treatment. That's about 15% of the population. So if you look at where they overlap, the purple area, or the overlap section, is what is key. This represents the percentage of people who are properly diagnosed and properly treated. The percentage is abysmal. 8% of people are properly diagnosed and properly treated. So if you look at what remains in the red disc, there is a substantial percentage of people who meet the diagnostic criteria for a disorder but do not get treatment. On the other side, the blue side only, you will see that there are approximately 7% of people who get some sort of treatment but no official diagnosis. So these are people who may receive medication for a disorder, let's just say from their general practitioner, but they don't actually have any kind of diagnosis of a clinical psychological disorder. So unfortunately, as it says on the bottom, not everyone who has a psychological disorder receives treatment, and not everyone who seeks treatment has a clear disorder. The last slide that has statistics on it, I think, is very revealing. Oh, I'm sorry, there's two more. Let's do this one first. This chart shows the portion of people who obtain treatment in the first year after the onset of the disorder. So if you take a look at the left side, you will see that there are a significant range of categories of psychological disorders, and then the percentage of people who actually received treatment. So people who were most likely to obtain treatment include people with bipolar disorder and people with major depression. Those two categories comprise upwards of 40%. Then we see people with generalized anxiety disorder or panic disorder. People with panic disorder experience panic attacks. That ranges in the 30%. Then it gets a little bit lower for drug or alcohol dependence, and the lowest rates of people who seek treatment is for phobic disorder and post-traumatic stress disorder, which is unfortunate. All of these percentages should be much higher. Now if you take a look at the next slide, this is the last slide I have with some statistics regarding characteristics of people who seek treatment, people who seek some kind of mental health service. If you take a look at the demographic variables, the first one that's shown in red is age. The age group most likely to seek mental health services are those people ranging in age from 35 to 44. So people who are younger don't necessarily receive treatment, and people who are older do not necessarily receive treatment. This can be for a lot of factors. This can be as a result of education. Those statistics are below, but it can also be because of lack of resources. Therapy is expensive. Therapy is not always covered by employers, and oftentimes people have to pay out of their pockets for treatment services, whether it be therapy or medication. So it would seem as though people who are in their prime earning years would be most likely to seek mental health services because at least they are partially provided by an employer, and or they would have the financial means to be able to afford the therapy, which might not be the case for the very young or the very old that you see here. In terms of race or ethnicity, people who are white are more likely to seek mental health services than Black or Hispanic. In terms of sex, women are much more likely to seek mental health services than men. In terms of education, this is broken down by years, but in general you can see the more educated someone is, the more likely he or she is to seek mental health services. And then in terms of marital status, the highest percentage is from those who are divorced or separated. And it's possible that the psychological problems the person is experiencing is a direct result of the divorce or the separation itself. So these are just some demographics to build a profile for those people who are most likely to seek services. As I just mentioned, cost is a huge factor in whether or not someone will seek services, and there is still a stigma among some people regarding seeking mental help services. Some people simply do not want to admit that they have a problem. Some people may perceive having a psychological problem as a sign of weakness, so they simply do not seek help for it, which is unfortunate. If you take a look at the next slide, I want to start talking about the different types of insight therapy. And the first one I want to go over is psychoanalysis. Psychoanalysis is the brainchild of our old friend Dr. Freud. This is Dr. Freud's brand of therapy. Psychoanalysis is a very common form of therapy approach. In some psychology graduate programs, students are trained based on Freud's analytical approaches to talk therapy. Because Freud believed that most psychological disorders were the result of unconscious conflicts or unconscious thoughts or unconscious wishes, he believed that the only way to truly, quote, cure a person or to help a person with his or her psychological disorder is to uncover those unconscious wishes and desires. So the goal of psychoanalysis is to reveal those unconscious thoughts or conflicts that are causing the problem. Usually psychoanalysis is most appropriate for problems with anxiety or depression, because those can be caused by conflicts that are buried deep in the mind. Psychoanalysis is not a short procedure. Psychoanalysis can take years. Often if people have something buried deep in their unconscious mind that causes depression or anxiety, it's not necessarily something they're just going to sit and start talking about in their first session. It is buried deep for a reason, and it may be years before it is finally uncovered. So this is a long-term therapy approach. The techniques that Freud used were many and are still used today. I'd like to mention two of them. The first one is called free association, and in this technique, the therapist simply asks the client, I'm going to say a word, and I want you to tell me the first thing that comes to your mind when I say this word. So I might say something like school, or father, or friend, just a word, and then start to see what the client says in response. It is possible that some of the words that the client says just off the top of his or her head may actually be something from deep in the unconscious mind. If a person is relaxed and something just pops in there, it may actually be fairly indicative as to what conflict is buried below. The other technique that Freud used extensively was dream analysis. There are several dream dictionaries available online that can allegedly tell you what your dreams really mean. Freud believed that dreams were a doorway to the unconscious mind, that dreams were a way for the unconscious mind to communicate with the conscious mind. So in dream analysis, he would ask the client what they were dreaming about lately and then try to analyze what those dreams meant. So in dream analysis, we have two parts. The manifest content is what the person actually dreamed about. Oh, the other night I dreamed that I was flying, or I dreamed that I was being chased by something that I couldn't see, or I dreamed that I was in a boat and all of a sudden all of these fish jumped into the boat. What you actually dreamed about is referred to as the manifest content. The manifest content is essentially the surface meaning in a dream, what you actually dreamt about, what you saw or felt or experienced. Freud's job was to then uncover the latent content. The latent content is the deep or symbolic meaning in a dream. So you dreamed about being chased. Let's see what that really means. What does that really represent? Or you dreamed about a lot of fish. What does that really mean? You dreamed about snakes. You dreamed about flying. So according to Freud, each dream had a deeper or latent meaning that was assumed to be a message from the unconscious mind. During psychoanalysis, Freud would often observe one of two processes happening. One phenomenon in psychoanalysis is called resistance. This is where a person is perfectly fine talking about a past experience or issue up until a point. And then he or she begins to resist going any further in the conversation. He or she might appear uncomfortable talking about it, or might try to change the subject, any way that he or she can resist talking about what the topic is. Freud took this to mean that a breakthrough was imminent. In other words, the client was getting to the core or the heart of the issue because he or she was resisting talking about it because it was oftentimes painful or uncomfortable. So resistance is when a client stops the progress in therapy, does not want to talk anymore about a particular issue, and usually that means that a breakthrough is very close. The other phenomenon that Freud observed that I want you to know is called transference. And transference is when a client would transfer his or her feelings about someone onto the therapist. For instance, having a boss who is a real jerk. So as the client is talking about this boss, he or she is actually becoming more and more agitated with the therapist. In other words, the feelings toward the boss have transferred onto the therapist, and the therapist is essentially becoming the substitute boss, where the client can actually express feelings about him or her without any worry about getting into trouble. So transference is when a client's thoughts or feelings about someone is transferred to the therapist, and the therapist becomes essentially a substitute target for those feelings. If you take a look at the next slide, you will see the second type of insight therapy that I would like for you to know. And this is called client-centered therapy. Client-centered therapy takes a somewhat different approach from psychoanalysis. Client-centered therapy was first started by a psychologist named Carl Rogers. And Rogers believed, unlike most client-therapist relationships, that therapists and clients were equal. So that was the first thing that Rogers wanted to establish, the equality of the therapist and the client. Only when both are perceived as equal participants in the therapy experience can progress be made. The goal of client-centered therapy is a little bit different from psychoanalysis. In client-centered therapy, the therapist will first try to understand the client's self-concept. In other words, how the client conceptualizes him or herself in terms of strengths and weaknesses. Then it is up to the therapist to make sure that the client's self-concept and reality are what he called congruent. In other words, your self-concept completely overlaps the reality of your situation. When there is not overlap, there is conflict. And where there is conflict, there are psychological problems. So for instance, let's say a person grows up saying, when I grow up, I want to be a doctor. I want to be a doctor. I want to be a doctor. But when he or she gets to college and starts taking biology and chemistry and calculus, he or she realizes, I don't like any of this stuff, but I want to be a doctor. I want to be a doctor. Even though I'm failing all of these classes and they hold no interest for me whatsoever, I want to be a doctor. No, I have to be a doctor, so I have to make this work. As you can see, there is conflict here. There is incongruence with that person's self-concept. He or she believes one thing on this side, but reality is telling him or her something else. The belief is, I want to be a doctor, I will be a doctor. Reality is telling this person, you don't really have that necessary foundation in order to be a doctor. These classes don't interest you. Therefore, you're not going to be successful in this. So once the therapist can begin to get the client to realize the incongruence, then he or she can be put on a better path to make them happier, to make them less depressed or less anxious. So the techniques used in client-centered therapy are widely used in therapy today. First of all, the importance of the use of the word client. For many years in therapy, people were referred to as patients. And what it communicates is really a sense that the person receiving the therapy is actually subservient to the therapist. That the therapist is the authority, the therapist is controlling the type, the pace, the rate, what happens in therapy. In other words, the client really is just more or less a subject of the therapist. By using the word client, Rogers helped put therapy in a better perspective. That is, the client is coming to the therapist for a service, to utilize a service, just like you might go to a lawyer for a service or call a plumber for a service. That it is essentially a partnership. That also guarantees that the client will be an active participant in therapy. When the two are not held as equal, it is much more likely that the client will feel as if it's the therapist's job to fix him or her, and he or she doesn't have to do any work. And nothing could be further from the truth. So use of the word client may seem minor, but it's actually very important in the psychological experience of therapy. You are an equal party. You are hiring a therapist for a service, but that also means that you have to put in your fair share of work to improve your psychological condition as well. Another technique used in client-centered therapy is what's called unconditional positive regard. The therapist's job is to set up an environment such that anything the client says will be held in the utmost regard and will be accepted and validated. That's going to make the client feel more comfortable to divulge information. So no matter what is said, the client will not be judged. That is critical. The client will not be judged, so he or she doesn't have to worry about saying something that might be strange or odd or weird or taken the wrong way. The therapist's job is to communicate this unconditional positive regard. Anything that the client says will be held in the utmost regard without any kind of judgment. The next technique in client-centered therapy is known as empathy. Empathy is a process by which the therapist tries to understand the client's situation from the client's point of view, not the therapist's interpretation of the client's situation, but the therapist really tries to put him or herself in the client's shoes, to see the situation from the client's perspective. That's really the only way that the therapist is going to be able to help. Oftentimes, empathy can be gained by the use of the next technique, which is called facilitative statements. Facilitative statements are very common in most forms of insight therapy. These are statements that are made to keep the conversation going, to get people to talk more, to open up, to explain what they mean, so that the therapist can have more empathy, can better understand the situation from the client's point of view. So facilitative statements keep the conversation going. One way that we can facilitate is to use what's called reflection. Reflection is when a client says something and the statement is repeated back in such a way so that the therapist is sure that he or she understands it. Now, it might just sound like reflection is just parroting back exactly what the client said, which may sound irritating, but that's not at all the goal. The goal is to better try to understand the client's position. What we don't do when we try to facilitate is to blame the client for his or her situation, to probe, in other words, ask probing questions, because probing questions are more like accusations. Facilitative statements are not ways to give advice, because again, even the therapist doesn't necessarily fully understand the client's situation, so the advice might not really be good advice at all, or giving a false reassurance, simply saying, oh, everything's going to be fine, don't worry about it. None of those techniques are facilitative. They will effectively shut down the conversation. If you take a look at the next slide, I want to show you some examples of cases where we're using facilitative statements and cases where we are not using facilitative statements. So the first example is that the client says, most people are liars. That's what's said during a therapy session. So we have two possible responses. Don't be so negative, and you feel that most people can't be trusted. If you take a look at those two responses, response B is facilitative. I'm not asking a question, I'm simply restating what the client said in order to better understand it. I want to keep the conversation going. Now you can turn this into a question by saying, so, you feel that most people can't be trusted? So you kind of leave it as a question, and that might get the client to talk a little bit more about what he or she meant by that statement. But simply to give advice and say, don't be so negative, really doesn't help the conversation flow and really isn't very therapeutic. Take a look at example 2. I hate school. Pretend this is coming from a child or a teenager or even a college student. I hate school. So one response is, it sounds like you're fed up with school. Another response is, what's wrong with school? Do you see how response B really isn't asking what's wrong with school? It's really asking what's wrong with you. That's the difference. That's why response B is not facilitative in this case, because it's almost an accusation. When you probe, you're almost accusing the person of having an issue or a problem in the first place. That's not going to keep the therapeutic environment flowing. Let's take a look at example 3. She stood me up again. So one potential response is, if I were you, I wouldn't ask her out again. Another response is, it hurts to be treated like that. Notice response A is giving advice. Even if it sounds like good advice, it's still giving advice, and you are not in that person's situation. You don't understand everything that encompasses that situation. So giving advice is not necessarily helpful or beneficial. Simply to say it hurts to be treated like that says to the client, I understand how you feel, or I'm trying to understand how you feel. I am validating your feelings and not doing anything else, not passing judgment, not giving advice, simply validating. Let's take a look at a few more on the next slide. Example 4, we just missed the deadline. One potential response is, that's disappointing. Another potential response is, why didn't you get it done on time? I think you're starting to see a trend here as to which response is going to be the most facilitative. Simply acknowledging the emotions felt, and in this case, the disappointment, probably is enough. That makes the person feel like he or she is being validated instead of being probed and accused of something that is allegedly wrong. Last one, I hope I pass the test. One potential response is, you're worried about how you did on the test. Another one is, don't worry, I'm sure you passed. Now, depending on the person who said this, we can see how response B might be okay. If this was said by someone who always gets A's on a test, that's a different situation. Here we have a problem with self-concept. Look, you've always gotten A's on the test. I'm sure you passed this one. In that situation, response B might be okay. But in general, it's better to use reflection and simply to say, you're worried about how you did on the test. Tell me more about that. That would be facilitative. That's going to keep the conversation going, and that is going to allow the therapist or you, simply as a friend or a sympathetic ear, to allow the person to talk about what's bothering him or her. So certainly these techniques aren't limited just to therapy. These are techniques that are used sometimes intuitively by people who are considered to be good listeners. They don't probe, they don't give false reassurances, and they don't give advice. If you take a look at the next slide, I'd like to talk a little bit about the last type of insight therapy, which is known as cognitive therapy. The goal of cognitive therapy is a little bit different from psychoanalysis and from client-centered therapy. In cognitive therapy, the goal is to change irrational appraisals of situations. In other words, to take a look at the cognitive piece of what is causing the psychological disorder. So again, the goal here is to change irrational cognitive appraisals of situation. If we can change irrational appraisals of situations, the emotional and psychological consequences are much better and much healthier. So we have two different techniques or two different approaches with respect to cognitive therapy. One is called rational emotive therapy. Rational emotive therapy. And this therapy technique was developed by a man named Albert Ellis. And Ellis was the one who came up with the ABC model of appraising situations. A is the activating event, so what actually triggers the cognitive response. B is the belief system. So if something bad happens to you in A, your belief system can either be rational or irrational. The rational belief system would be, this was a bad thing that happened, it's unfortunate, but I'm going to make it through and I'm going to be okay. The irrational appraisal of the situation is, this is terrible, this is horrible, I'm never going to get out from under this situation, I don't know what I'm going to do. So the belief system, or B, will then dictate the consequence, which is C. In other words, your emotional and psychological consequence. If you had a rational cognitive appraisal, you might feel upset, but at least you're calm and aware that you have resources and you have options to address the event that happened. If you made an irrational cognitive appraisal, you are most likely going to be upset or anxious or worried or even angry at the situation, which makes you less able to cope with it effectively. So, the key here is the B part, the belief system. If you have a rational belief system, the consequence will be much more favorable. If you have an irrational belief system, the consequence, of course, is going to be much less favorable and make you less equipped to handle or deal with the situation. The second type of cognitive therapy that I want you to know was first developed by a psychologist named Aaron Beck. And Aaron Beck's model of cognitive therapy is a little bit different from Ellis's. In Beck's conceptualization of cognitive therapy, the goal is to correct cognitive distortions, and I'm going to go through a few examples of those, and then also to avoid what he called primitive thinking. So correct cognitive distortions and avoid primitive thinking. So let's take a look at the next slide. And first we can go through common cognitive distortions. So you see it's a pretty long list of cognitive distortions that people engage in. And we do this all the time. The goal here is to recognize when it's happening so that we can change them. The first cognitive distortion on the list is called catastrophizing. This is when we weigh an event as being too important. In layman's terms, this is when we make a mountain out of a molehill, that every little setback is a crisis or a disaster. You may know people like this. People who are catastrophizers tend to have a lot of experience of anxiety, because to them, everything is a crisis. Everything is a big deal. Everything is a huge event. So they're not able to prioritize their resources to address what is really important and what is not, because to them, everything is a four-alarm crisis. So weighing an event as too important or encompassing too much of your existence is known as catastrophizing. The second one is called dichotomous thinking. A dichotomy is really when you only have two options, or there are only two possibilities. So in dichotomous thinking, people will frame a situation as being either or when there are actually other options. So in other words, an example might be a person loses his or her job. So option one is that they have to get rid of everything that they own so that they can keep their house, and the other option is that they just have to walk away from the house and get foreclosed on. Those are two horrible options. Neither one is a good option, and they don't think about ways that there could be a third option, ways that they could negotiate for some things or sell some things but not other things. In other words, there is no in between. There is no third possibility. It's an either or situation, and usually both of the possibilities are extremely negative ones. The next cognitive distortion is known as fortune telling. Fortune telling is when a person anticipates that events will go badly. He or she has an event to go to and is sure that it's going to be a miserable time. Or the person has a speech to give and is sure that he or she is going to mess it up, or a job interview, or whatever the case may be. So in fortune telling, you anticipate that events will turn out badly. Often people are pleasantly surprised, but because there's so much anxiety during the build-up, that almost takes precedence over the relief and enjoyment that they feel afterwards. They can't, because they had that negative build-up toward the event. The next one is called mental filter. And this is when people ignore either the positives or the negatives of an issue. Usually people who have problems related to anxiety will find it easy to avoid thinking about the potential positives of an issue. For instance, if you're in a situation where you have to move, moving is a big deal, to be sure, but you'll get a chance to learn about a new geographical area, meet new people, have new experiences. People who are using a mental filter will discount all of the potential good. They only see the potential bads of the issue, the potential negatives. Sometimes in a mental filter, people will avoid thinking about the negatives of an issue, but that's the less common of the two situations. The next cognitive distortion is called mind reading. And this is when a person believes that he or she knows what someone else is thinking simply by their behavior or simply by the conversation that they're having. So two people can be having a conversation and the one person can say, "Look, I know what you're thinking about this, so just hear me out," when really the person doesn't know what the other person is thinking at all. So mind reading is when you believe you know what the other person is thinking, and that may or may not be true. The next cognitive distortion is known as overgeneralization. That is, one event is taken as evidence of a pattern of events. So, classic example, a person forgets to pick up somebody else. And the minute that they do come around and get you, you say, "You are always late. You always forget to do things. You always disappoint me." In other words, one event is assumed to represent a pattern of events, whether or not that is actually true. And the last one is known as should statements. I should be doing this. I should be doing that. I should do this. I should think that. Should statements should be avoided at all costs because they are demands that we make of ourselves to avoid perceived irresponsibility. If you can admit that you should be doing this or should be doing that, at least you're trying to make yourself feel better, that you're not an irresponsible person, when what you're actually doing oftentimes is putting unrealistic demands on yourself in the first place. So you feel bad about something you feel that you should be doing, because at least if you say should, that means you're not irresponsible, but the demand that you make on yourself is usually unrealistic or unnecessary to begin with. So people end up getting caught in a cognitive loop. So any of these cognitive distortions can lead to potentially disordered thinking, because it is very easy as a result of chronic cognitive distortions to begin experiencing symptoms of anxiety or depression, because none of these cognitive patterns are psychologically healthy. None of them are. Most of us will engage in them from time to time, but when they are chronic and habitual and sort of override realistic and rational approaches to thinking about a situation, that's when it can lead to serious problems with depression or anxiety. If you take a look at the next slide, you will see Beck's other contribution to cognitive therapy, and that is the difference between primitive and mature thinking. Primitive thinking has characteristics that are all pretty much negative. Mature thinking is much more positive, realistic, and rational. So, for example, primitive thinking is global. I say to myself, "You know what? I'm just a failure. I am just a complete and utter failure." That's global thinking. I am a failure. Totally. Specific thinking. I make mistakes sometimes, but I am good at many things. So see the huge cognitive difference this will create. On the one hand, you're saying you're a failure. That is global, totally. Everything you do or say or think, you fail. But to be realistic and specific, you can say, I may have failed at this one thing, but I am not a failure. I make mistakes sometimes, but I am good at many things. The next discrepancy in primitive versus mature thinking. Primitive thinking is moralistic. I am a bad person. In other words, there is an inherent moral judgment in there. I am a bad person. Mature thinking is non-judgmental. I sometimes let people down, but I can make amends. So instead of saying that you are bad to the core, you're rotten to the core, you can say, you know what? Sometimes I let people down. Sometimes I am a bad person, but I can make amends to them. So it is actually not judgmental. Primitive thinking is invariant. An example would be to say something like, this situation is hopeless. When you say something like that, there is no chance for any change in that situation. It is invariant. Mature thinking would say, there may be a way. So you see a little bit of overlap with cognitive distortions here. In mature thinking, instead of saying, this is totally hopeless, you say there is a way, possibly. This situation is variable. Next, in primitive thinking, we base assessments on a character diagnosis. An example might be, I am a coward. Mature thinking is based on a behavior diagnosis. I am behaving like a coward right now. Huge difference in the perception. Rather than saying this is what I am, you are saying this is how I am behaving right now. Because what that means is that behavior can be changed. It is not enduring, and you have control to change how you're behaving because it doesn't necessarily reflect who you actually are. And lastly, primitive thinking is irreversible and rigid. Kind of going back to the idea of invariant. There is nothing I can do about this situation. That is rigid, inflexible, primitive thinking. There's nothing I can do. Reversible and flexible thinking is much more mature. Let's see what I can do to fix this. Let's see what I can do to fix this. It is much more flexible, allowing yourself to see the possibilities. So people who are mature thinkers are much more likely to have less experience with problems in things like anxiety and depression because, again, their cognitive appraisal of the situation is much more realistic and rational, and it allows for options and solutions to problems to be found. Primitive thinking does not, and unfortunately then people are caught in a cognitive loop that leads nowhere, that leads to nowhere except depression and anxiety. On the next slide is just an example of a transcript between a therapist and a patient, so you can begin to see how cognitive therapy works. So the therapist says, you said that you should have done better on the exam. Why? The patient, because I'm smart and I should do the best that I can do. Therapist, what is the best that you can do? Patient, I could get straight A's if I really applied myself. But since you're not always getting straight A's, it seems that you are not perfect. Should you be doing things that you might not be capable of? Maybe if I tried harder, I'd get straight A's. What are the costs and benefits of demanding perfection? The costs are that I feel pressured and disappointed. The benefits, maybe I'll try harder. So how is it working? I'm miserable. Okay, so right there, the patient, well, we probably should say client, is admitting that his or her cognitive issues are actually having the emotional consequence of feeling miserable. He or she is putting himself to such a high standard and demanding things that at this time he or she is not capable of. We see a problem and we see an emotional outcome. The patient is miserable. So the therapist, what if you had a standard that said, I'll try to do a good job? What would be the benefit of that notion compared to demanding perfection? Maybe I wouldn't feel overwhelmed. Do all your friends get perfect grades? No, some of them are barely getting average grades and some get good grades. No one I know is getting straight A's. What do you think of them? They're doing okay, maybe I'm tougher on myself. What if you applied the same expectations to yourself? I'd be a lot better off. So the recognition that maybe there is some aspects of unrealistic, irrational appraisal of the situation is leading to the emotional consequence of feeling miserable, and now we begin to see some more of that rational cognitive input. So maybe if you set more realistic expectations of yourself, just like you set for your friends, then you might feel a whole lot better. So this is where cognitive therapy can really be effective. It can take people from one irrational cognitive place and try to put them in a much healthier cognitive place. If you take a look at the next slide, I want to talk about the last treatment approach that I would like for you to know, which is biomedical therapy. The first one that I want you to know is essentially a fancy name for therapy by medication. Psychopharmacotherapy. So this is medication that is used specifically to address imbalances in brain chemistry. So the goal is to remedy affected neurotransmitter systems, to restore the balance in the neurotransmitter systems that are affected and are potentially causing problems that yield in or that result in a psychological disorder. So we have several different categories of medications that I would like for you to know. The first category are medications used to treat anxiety, anti-anxiety medications. Most anti-anxiety medications, not all, but most work in the GABA system. Their job is to enhance or increase GABA functioning, particularly in the frontal lobe of the brain. Most anti-anxiety medications work by increasing GABA function. You might know some of these or at least be familiar with the brand names: Xanax, Librium, Klonopin, Transine, Valium, Ativan. These are common anti-anxiety medications that all work in the GABA system. Some sleeping aids like Ambien and Lunesta also work in the GABA system as well. So they're more to treat sleep disorders than actual full-blown anxiety, but the mechanism by which they work is the same as most of these other drugs. So again, the goal here is to enhance GABA functioning. Next, we have a category of drugs that are known as mood stabilizers, and these are used to treat bipolar disorder. Some of them work in the GABA system. In other words, they enhance GABA function. Those medications for bipolar disorder include Depakote, Tegretol, and Neurontin. You're not expected to remember all of these names. I just want to give you some names, so if you're familiar with that class of drugs, you will understand how they're used. Other medications for bipolar disorder work in ways that we don't fully understand. The most commonly prescribed medication for bipolar disorder is called lithium. And lithium is a salt. It's on the periodic table of elements. It is just a regular salt, a regular chemical compound. So some people who take Librium for bipolar disorder take it under the brand name Escalith or Lithabid. And both of these are drugs that are not proprietary by the drug company. The drug company did not make lithium, but how it is packaged and how it gets released may be proprietary. But no one actually owns Librium or lithium because it is just a salt. We're not really sure how lithium works, but it does work to control the manic episodes in bipolar disorder. In other words, it takes the extreme highs and flattens them out a little bit. Unfortunately, lithium does have some pretty severe side effects. It can make people extremely drowsy, it can make them not feel very well, and it can also lead to weight gain. And of course, most importantly, to someone who has bipolar disorder, lithium takes away the manic episodes. And the manic episodes are the good ones that people who have bipolar disorder really enjoy experiencing. So unfortunately, there is some problems with compliance. People don't always want to take lithium when they really should because of the side effects and because it does remove that high, that manic phase. It flattens affect a little bit more. The other potential problem with lithium as a treatment for bipolar disorder is that lithium can be very, very toxic if the recommended dose is exceeded just a little bit. So if you have someone who is not particularly responsible about taking medication, and let's say that he or she is told to take this medication X number of times a day at these certain times during the day, and then he or she forgets and says, oh, I'll just double up the next day, no problem. That can land that person in the emergency room. Lithium goes from being therapeutic to being toxic very, very quickly. So this is not the medication for someone who has a problem with compliance or is just irresponsible when it comes to taking medication. The next category that you see on this slide are antipsychotic medications. So these medications are used to treat schizophrenia and other forms of psychosis. Some of the older antipsychotic medications worked primarily in the dopamine system, and their job was to reduce the amount of dopamine. Schizophrenia is believed to be caused by too much dopamine in the brain. So older antipsychotic medications work by reducing dopamine levels only. Newer antipsychotic medications can block both dopamine and serotonin activity at receptors. So two neurotransmitters are involved, both dopamine and serotonin. So I just want to read some of the traditional schizophrenia medications or antipsychotic medications and then some of the newer ones. The old classics are Thorazine and Haldol. Those are the two probably most well-known medications for schizophrenia. Thorazine was the very first antipsychotic medication given. Soon after, Haldol came around. These are still used today, although Thorazine is a pretty heavy-duty drug and not given in all circumstances. Haldol is still a fairly common antipsychotic medication that is given. Now, some of the newer ones that have come along in more recent years include Seroquel, Geodon, Zyprexa, and Abilify. Seroquel, Geodon, Zyprexa, and Abilify. These are newer antipsychotic medications, and some of them are also used in the treatment of bipolar disorder. So in other words, they can be prescribed for bipolar disorder or for schizophrenia, depending on the particular symptoms that the client is having. So some of the newer antipsychotic medications work in both the dopamine and serotonin systems. They decrease the levels of both of those neurotransmitters. There is a risk for some of the older antipsychotic medications, and there are many besides Thorazine and Haldol. There are several other medications used to treat schizophrenia. But in some of the older medications, or for people who have been on these medications for a long time, there is a very specific risk for a side effect known as tardive dyskinesia. Tardive dyskinesia. This is a side effect in which people begin to develop uncontrolled movements. Their arms may start to shake, their hands may start to shake, they may have uncontrolled facial movements, like their mouth starts to move in strange ways, or their eyes open and close, and the client cannot control those movements. So tardive dyskinesia is when we observe uncontrolled body movements as a result of long-term antipsychotic medication. For some of the older antipsychotic medications, the risk of tardive dyskinesia can be between 30 and 40%. That is, 30 to 40% of people taking these medications long term can develop these symptoms. So it is certainly something that must be discussed with the person prescribing the medication, and also something that has to be checked for very frequently, because it is a very serious side effect. If you take a look at the next slide, you're going to see a list of one of the largest categories for psychopharmacotherapy, and that is the antidepressants. Many antidepressants are available, obviously, for the treatment of depression. In terms of their development, the first category of antidepressant medications came about in the 60s, and these are known as MAO inhibitors, or shortened form MAOIs. You may hear the term MAOI when you hear commercials for certain medications, because sometimes if you're on one medication, you cannot take this class of drug. So listen if you're watching a commercial about a drug. Usually at the end they have a disclaimer where they say very rapidly, do not take this medication if you are currently taking an MAOI. Well, now you know what it is. An MAO inhibitor. MAO stands for monoamine oxidase. Monoamine oxidase is an enzyme that normally breaks down serotonin, dopamine, and norepinephrine, 3 neurotransmitters. MAO normally breaks down serotonin, dopamine, and norepinephrine. So an MAOI is going to inhibit or block the breakdown of serotonin, norepinephrine, and dopamine. It is believed that depression can be caused by levels of these neurotransmitters that are too low. So serotonin is too low, norepinephrine is too low, and dopamine is too low. So if we can block their breakdown, we are effectively increasing their levels in the brain. And that's exactly how an MAOI works. We are effectively increasing serotonin, norepinephrine, and dopamine levels by blocking their breakdown in the brain. The 2 most common MAOIs that are prescribed are called Nardil and Parnate. And like I said, these medications have been around for a long time, since the 60s, but for some people they are the most effective antidepressant that they can take. However, MAOIs do have one particular problem, and that is there are some significant dietary restrictions that come about with taking an MAOI. When you're taking an MAOI, you must avoid foods that contain a substance called tyramine. Tyramine is present in a lot of foods. If you give someone an MAOI, levels of tyramine start to increase, and tyramine can result in a blood pressure spike, and unfortunately that can lead to stroke. So the bottom line is people who are taking MAOIs often have some dietary restrictions. I want to read the list of some of the food restrictions so you can decide whether or not you would be able to tolerate an MAOI. Okay, so here's the foods that you must avoid: cheese, yogurt, sour cream, sausage, pepperoni, bologna, beer, wine, most liquors, coffee, tea, cola, and probably the biggest one, chocolate. These are foods that you have to avoid if you're taking an MAOI. So if that would result in a real quality of life issue, this is not the antidepressant for you. The next class of antidepressants that I want you to know are known as the tricyclics, or tricyclic antidepressants. Tricyclics are named because of their actual chemical structure. The chemical structure of a tricyclic is 3 rings, 3 interlocking rings, hence tricyclic, 3 little circles. This is a very large category of antidepressants. Let me give you a few examples of tricyclics: Elavil, Tofranil, Vivactyl, Sinequan, Pamelor, Aventyl. These are all just common examples of tricyclic antidepressants. These medications work by blocking the reuptake of serotonin and norepinephrine. When I say that, what I mean is the presynaptic cell that released the serotonin and norepinephrine will eventually take it back up from the synapse. Tricyclic antidepressants block that process. So if the reuptake is blocked, the net effect is that more serotonin and more norepinephrine are available in the synapse to keep stimulating receptors on the postsynaptic cell. In other words, more serotonin and more norepinephrine is available. So the net effect is the same as with an MAOI, more serotonin and more norepinephrine in the system. Tricyclics were first developed in the 70s, and the only real problem with them is that an overdose of tricyclics can be fatal. These are not medications that you would give to someone who has symptoms of depression, in which one of the symptoms has to do with thoughts of suicide or actual suicide risk, because it doesn't take much more than the therapeutic dose to actually be fatal. So this is something that during the screening and during the determination as to what medication should be given, that must be taken into consideration. TCA should not be given to people who have a suicide risk. The next class of antidepressants is one that is really well known thanks to the publicity of them: the SSRIs, selective serotonin reuptake inhibitors. So this is in contrast to the tricyclics. SSRIs only block the reuptake of serotonin. They are selectively inhibiting the reuptake of serotonin, so they don't have any effect in the norepinephrine or dopamine systems. These first came out in the 80s, and this class of drugs is very well known to most people. The first one, Prozac. And then we also have Paxil, Zoloft, Luvox, Celexa, and Lexapro. So those are all SSRIs. They selectively block the reuptake of serotonin. These are commonly one of the first medications that are prescribed when someone is experiencing symptoms of depression. All antidepressant classes, no matter what kind, whether they are an MAOI, a tricyclic, an SSRI, or even one of the newer antidepressants, all of these medications have about the same effectiveness rate, and that is somewhere between 60 to 80%. So the average is about 70%. So antidepressants don't work for everybody, but you shouldn't think that one particular drug just works better in general than any other drug. That's not true. It depends on your individual chemistry. So all antidepressant medications are between 60 and 80% effective. SSRIs, since they have been so well studied since their introduction in the 1980s, do have some known side effects. The two that I want to mention are problems with sleep and problems with sexual functioning. SSRIs can cause what is known as micro-awakenings. That is, people wake up and may not even realize they're waking up and then falling right back asleep over the course of the night. So people wake up maybe for just a minute or two, might not even realize that they're actually awake and fall back asleep. So the problem is when you have your sleep cycles interrupted over the course of the night, you may wake up still feeling tired but not knowing why, because you might say, well, I got 8 hours of sleep. I don't understand why I'm so tired. So that's a potential side effect. The other potential side effect worth mentioning with SSRIs is sexual side effects, most noticeably a decrease in libido or a decrease in sexual desire. Very common side effect that is reported, and that can become a quality of life issue too. So if you or someone you know is experiencing tiredness or problems with libido, it is definitely worth talking to a therapist or doctor about. There are some newer antidepressants out there. Some of the ones that are being heavily marketed currently are Cymbalta and Pristiq, and I'm sure there will be more down the road as well. These medications block the reuptake of serotonin and norepinephrine. In other words, drugs like Cymbalta and Pristiq are similar in function to tricyclics. They block the reuptake of serotonin and norepinephrine, effectively leaving more in the system. The net effect is that serotonin and norepinephrine levels are raised. So again, the newer the medication does not necessarily have any, or does not bear any indication that they are better than the older antidepressants. There are several available to people. The unfortunate thing about antidepressant medications is that most of them, no matter what the category, usually take about 2 weeks to kick in. In other words, people have to wait about 2 weeks of taking the medication before they actually start to feel the effects. And if you're trying different medications, trying to feel better, sometimes that can seem like a really long and tedious process. But just give it time. It will eventually work, and there will be one that could probably help someone who has problems with depression. The last biomedical approach that I want to mention is ECT, which is known as electroconvulsive therapy. If you go to the last slide, the slide after this one shows an example of how the different antidepressant medications work at the level of the synapse. But if you take a look at the last slide, I wanted to show you some pictures about the perception of ECT and then the reality of ECT. The perception is often a byproduct of how it is portrayed in the media and some historical context as well. ECT is unfortunately been given the name shock therapy, and when you see it being shown in a movie or on a TV show, actually it's often made to look like something that is just short of torture, and it is simply not true. ECT is a medical procedure like getting a cavity filled. It is a very controlled procedure. There are places in town that can actually do ECT. It's a very regular, scheduled, routine procedure. ECT is usually reserved for cases in which people do not respond to antidepressant medication. Remember what I said before, antidepressant medications are usually about 60 to 80% effective. So that leaves, minimally about 20% of people who do not respond to them, who need some other kind of therapy, but can benefit from a biomedical approach to somehow changing the brain chemistry. These people then become candidates for ECT. During ECT, you go into the facility and you are given muscle relaxers so that your muscles relax during the procedure. If you take a look at the images here, what happens is that a small current is applied across the temples of your forehead just for a few seconds. As you can see, there are two pictures that show a small implement placed in the patient's mouth. That is to make sure that the patients do not do any damage to their mouth or tongue immediately after the treatment is given. When electricity is applied in that way, the result is going to be a small, brief seizure. That is the body's way of expelling the excess electricity that has just come in. So after the electricity is applied, there will be a small seizure that happens afterwards. So all safety precautions are taken to minimize any kind of harm caused by the seizure. So that's why muscle relaxers are given, so that the muscles relax so they don't move that much, and that is also why something is placed in the patient's mouth. But you'll notice during the time there is monitoring of the patient's condition, EKG, blood pressure, all of those things are closely monitored. So the whole process only takes on the order of a few minutes. Most of the time spent during ECT is for the prep, to get the patient ready for ECT and to administer the muscle relaxants, and then to make sure that all of the monitoring equipment is checked and also working properly. So the only real side effect that is experienced in today's ECT is brief amnesia. Sometimes people may experience brief anterograde amnesia because the process of consolidation is interrupted by the application of the electricity. So they may not remember actually coming to the facility or actually being wheeled into the room to receive ECT. But other than that, the patient, after receiving the treatment, might sleep for a half an hour to an hour in a recovery room and then get up and leave. And that's it. Because the amount of electricity that is applied is so small, there usually aren't that many long-term memory deficits or other problems. ECT as a clinical procedure is usually applied every other day for about 2 weeks, and then the person can go for as long as 6 months until any additional treatment is needed. So it could be every other day, could be maybe twice a week for 2 weeks, and then maybe no more treatments are needed for half a year. So again, this is a very safe, medically supervised procedure that unfortunately has a negative stigma attached to it, thanks once again to Hollywood. This is the end of the lecture on treatment for psychological disorders.